Thanks very much. It's a pleasure to be here with you tonight. So we've probably met some of you already. For those I've never met, my name is Dr. Edith Gara, and as just Abrick told you, I'm a cardiologist, and I also have background in pre-hospital care. I used to work a couple of years with the Hungarian emergency care, also on the helicopter service for a couple of months. So currently I am based in Hungary, in Budapest, and tonight I would like to share some interesting cardiology cases with you. And I have planned this event as a really interactive case session. So please feel free to interrupt me at any moment with any question, comment, or when something is not clear, then we can discuss that more. So I share my screen with you, so you will be able to see the slides. Okay, just a sec. Okay, I think you see my slides now, right?
Yeah.
Okay. Okay, so we can go ahead and start with the first case. In this scenario, you are a medic at an oyster construction environment. And there is a 43-year-old male complaining about some leg cramps and some swollen ankles. He also tells you that he has fatigue today and he is unable to work as usual. Okay, you approach him and you do the primary vital signs. You see them on the right. The CRT is 3 seconds, the pulse rate is around 60, the respiratory rate is around 20, and the oxygen saturation is 97. So you start to interact with him and get a couple of information. He tells you that he has these swollen legs since last week. He has some allergy to penicillin. He has hypertension from the past, and he shall take some blood pressure tablets, which he cannot name. And it's really not sure if he takes them at all, or he takes it every now and then. So the compliance of this gentleman is not so good. So he has this hypertension in the past. He's deaf to one ear, and he denies any previous further cardiac condition. The last meal was his breakfast, and when you try to get some more information, he complains about fatigue. Also, when you inquire how is the work was going for him today, he tells some shortness of breath on exertion. He denies any pain, and some tiny more information that he had some fever last week, and also it was presented with diarrhea. Okay, so this is where you are standing now, and I would like to hear your first impressions according to his complaints and according to the first information you have. What's on your mind? So the floor is up to you to discussion. Yeah, Trevor, go ahead.
Fluid retention. It's kind of vague, like heart failure-like symptoms.
Very good. Yes, so the swollen legs is definitely suggestive of fluid retention edema, which could be related to heart failure. What else is a symptom of heart failure here? Or possible heart failure? So the shortness of breath on exertion,
Okay.
it's yeah, sorry, Nelson, go ahead. The fatigue, yeah, very good.
Hypertension, east of hypertension.
Yeah, so the hypertension itself, as far as he doesn't have a good compliance to the medication, it could be that he could be in a hypertensive excess, which could exaggerate a worsening of a heart failure or can trigger an acute heart failure. Very good point. Okay. And Dennis, yeah?
Does this person, when you listen to his lungs, does he have any adventitious sounds?
Yeah, good. When you listen to his lungs, you can hear some crepitation-like sounds on the base. Could be some fluid retention in the lungs as well. That is the auscultation result of the lungs. Good point. Emmanuel? Yes, go ahead, Emmanuel. We can't hear you at the moment. I think you are muted. Okay, no worries.
This patient could also
yes.
have edema of the feet, pedal edema in the long term.
So pedal edema on the feet, yes, it is present from last week, so it's going on for a while. So something might have happened last week. Okay, what do you think about this piece of information that he had fever and diarrhea last week? Could this be relevant to his current symptoms? Martina, yes? Oh, you left the meeting, no worries. Okay. Anybody, any clue about the fever and diarrhea? So what could have happened last week? What was the reason behind the fever and the diarrhea? What's the most common reason?
Viral gastroenteritis.
Yeah, very good, very good. You can say COVID these times, but it's it's not compulsory to be COVID, but it could be COVID as well, unfortunately. Very good, viral gastritis. So it might have happened to him that he had some viral infection affecting the gastrointestinal system, causing the diarrhea and the fever. Any relation with any cardiac condition with a viral?
I'd imagine if any kind of infection is going to kick off some kind of inflammatory process, that if he's already been seeding his valves, could exacerbate things.
Yes. Yeah. So when we are talking about infection on the valves, that condition is called an endocarditis. which is a bacterial disease when you have a so-called vegetation on the valves, which is a bacterial stuff just unfortunately exactly eating the valves. And that's a really life-threatening and severe disease. So that's one direction to think about in our diagnostic setup. What else could be? And Martina, yes?
Maybe pericarditis due to the previous viral infection.
Yes, very good. Pericarditis is quite common in viral infections, and not just the pericardium, but the myocardium itself can suffer an inflammation. So it could be a pericarditis or a myocarditis as well. And you must have heard that there are some COVID myocarditis cases as well. Not so many as we were suggestive of when the pandemic just started, but there are some. The thromboembolic events are more frequent with COVID. But it's very well known that gastrointestinal viruses can cause severe myocarditis. Okay, so at this point, we are just having these suggestions. We're trying to have a build-up in our head what's going on with this gentleman. And he is quite young. Remember, he is 43. Okay, let's go on. And you do the secondary assessment where you can't find any visible catastrophic hemorrhage. The airway is clear. The breathing is normal. He's slightly typnoic. No bleeding. He's alert, communicating very well with you. And he is doing this hard physical work for a while now. Okay, you do the full set of vital signs where you see that the CRT is 3 seconds, the pulse rate is 57, respiratory rate 19, the oxygen saturation is 97. You get the blood pressure, which is, I would say that this is in a gray zone. Would you feel that with this blood pressure, it's a hypertensive emergency scenario, or the blood pressure is the bad guy? I mean, the blood pressure is causing the heart failure. So it's 140 over 80.
I guess it depends where his baseline here, where he's hypertensive to begin with.
Mm-hmm. Yes, very good point. So if his usual blood pressure is 110 over 60, then this might be a significant increase to him. Mostly with this blood pressure, I wouldn't feel that this is exactly a trigger for the acute heart failure. It would worsen the situation. Okay, so you're getting an ECG. Patient is alert. You get the blood sugar level, which is good, and currently he doesn't have fever. But you see, and he also complains some sweating, which is again a sign of
potential sympathetic discharge after ischemia.
Yeah, so usually in acute ischemia, they have this cold sweat, but also very often we see it in acute heart failure. Okay, so here comes the ECG. And I leave the big image on for a while, so you can all have a look and analyze. And meanwhile, you are doing that. I'm putting on my short checklists for ECGs, which I'm always doing in my mind when I'm checking an ECG. So first thing first is that you have to decide what's the rhythm, whether it's sinus. If not sinus, then what's going on. You always look for the P waves, try to find them, and you try to find the correlation between the P waves and the QRS, and then evaluate whether it's sinus. If not sinus, then you decide what is the rhythm. Then you always assess the PQ interval. You have a look for the QRS, whether it's wide or it appears normal. What's the morphology like? Is there a bundle branch block? Is there a hemi block? You look for the ST segments. Is it electronic, or is there any ST elevation or ST depression? Any J point elevation? You look for the T waves. Are they concordant? Is there any abnormality? You quickly assess the QT interval, and you look for any other strange findings on the ECG. So this off. And I just waited for a couple of seconds to let you analyze this. And once you are ready, you can start telling us your thoughts.
Can I go?
Sure, go ahead.
It looks like this is sinus rhythm with a trifascicular block, because there's a right bundle branch. There is looks like a left anterior fascicular block with inverted QRS and lead 2. And there's also a first degree AV block.
Yes.
There's a few flat and inverted T waves in one AVL. But other than that, I don't see like huge like STEMI-like elevation or anything like that.
Okay, super, very well done. So yes, so the rhythm is sinus, but the PQ interval is enlarged. So we have a first degree AV block. We also have the right bundle branch block, and we have the hemi block. Very, very good point. And yes, otherwise very well summarized that you might say that we have some tiny ST differences, but they are not significant. So I wouldn't say that this is an ischemic ECG, or I wouldn't say that this is an acute coronary syndrome, definitely not a STEMI. And according to the T wave abnormalities, it could be anything. So the T wave could suggest some ischemic background or non-STEMI, but with a blink diagnosis, I would also say that this is a trifascicular block, so something bad is going on in the heart, and it doesn't appear as an acute coronary syndrome ECG, and also the patient doesn't have that kind of symptoms. Okay, questions or comments to this ECG?
If in reference to bifascicular and trifascicular blocks, are they always to be considered, like if they're new, are they always to be considered like a critical sign, critical finding?
Yes, how do you mean critical finding? I mean, yes, I would be, don't say I'm worried, but I would take really, really good care and really close cardiovascular monitoring on a patient with bifascicular, trifascicular block, which is new onset with cardiac symptoms. So this chap here, he's having shortness of breath, swollen legs, signs of heart failure, and has a weird ECG. So he definitely needs a close monitoring, and we need to find out what's going on. If, the other way around, if we have a trifascicular block for 3 years back from the history of the patient, and it doesn't change patient is in stable condition, he didn't have an AV block or a symptomatic bradycardic event, then that's another situation, and then you can do elective diagnostic steps. So that's another situation. But with new onset bi or trifascicular block, yes, that's a critical condition. Okay. So this is where we are standing at the moment. And for these questions, so the differential diagnosis, is there anything on any more condition on your mind which we haven't touched on yet? Or would you, at this point, would you do any more diagnostic steps, or would you do any further physical exam?
It'd be great to have ultrasounds and have and get a couple of like per sternal long and short view.
Okay, you actually your equipment is a very fancy one and very well equipped. So you have a pocket ultrasound, and you can connect that to your iPhone, and you have a fairly good image. So you obtain the parasternal long and short axis and a quick apical view of the heart. And what you see is that the pump function is in the mid-range. So there is some decrease in the systolic function. So you see that the wall motion is not as good as it should be. And otherwise, you can't find any pericardial collection, so no fluid, just the normal amount. And this is what you can assess with your pocket ultrasound. So the new information is that you have a decreased left ventricular ejection fraction.
Yeah, I think that confirms the initial idea of heart failure.
Mm-hmm. Yes, definitely. So, Martina, you raised the hand. Did you?
No, sorry, by mistake.
Oh, okay, yeah, sorry. Nelson?
Yeah, now I would also want to do the CKMB or the cardiac enzymes on the investigations.
Yes. So you used to have a quick troponin test, but you just unfortunately run out of that, so you can't do that point of care test at the moment. So the troponin or the CKMB would only be available later on in the emergency department or in the hospital. Yes, Dennis?
So let's say we did have the troponin.
Mm-hmm.
How is that going? We already are traveling down the line of this is heart failure. What is that going to tell us more than what we already know?
Yeah, good point. So I think, the troponin, the high sensitive troponin. So nowadays in cardiology departments, we are using the high sensitive troponin, which is positive in almost the most tiny myocardial injury. We'll do it sky high positive. So yes, it wouldn't really help the differential within the cardiology cases, because it would be positive from a paroxysmal atrial fibrillation episode, and it is positive from an acute heart failure episode. And of course, in a STEMI, the trend is different, so somehow we can do some differentiation. But yes, so with an acute heart failure, we await a positive troponin test. Of course, it's not that high, and the trends are different than in an acute coronary syndrome. Even better for if we are talking about the biomarkers of acute heart failure. Probably you knew another one, which is specific for the acute heart failure. Yeah, and for the chronic, so for heart failure.
Would we
Yep.
would we withhold care if the troponin was high normal?
You mean would you rule out an acute heart failure because of a negative troponin? No, I would say no. Yeah, it depends on what time the troponin was taken, and I mean the high sensitive one would be definitely slightly positive in acute heart failure, but the old troponin T and troponin I tests, they are not so sensitive, so it might be that they are not positive with an acute heart failure, which is not so severe, so the patient is not in a the New York Heart Association is for the classification of heart failure, when class 1 is the bad, so that's the not so severe one, and class 4 is the most severe one. So yeah, when it's not a so severe heart failure, I would say that the old troponin tests could be that they are not positive. Okay, so I write here the other test in the chat. It's called an NT-proBNP. It's N-terminal pro-brain natriuretic peptide. Have you heard about this? This one is a specific biomarker for heart failure, which is widely used in cardiology emergency departments as well. And this peptide is produced from the atrium, from the atria. And when there is a heart failure and volume overload, then the atrial walls are quite stressed, and volume and pressure overload is the trigger for the production of this peptide. And this peptide is sky high in acute heart failure, and it has a really strong predictive value of the outcome of the heart failure. I mean, you can follow up the patient with the BNP levels. So when it's starting to decrease, then the heart failure is getting better and the patient is getting some relief. So it's good for longer term monitoring as well for patients with chronic heart failure. I'm just thinking about, I'm not aware of a quick test of BNP available for pre-hospital care. So at the moment it's only tailored for in-hospital management. Yes, Michael?
So let's say that, this is a patient we have in an austere or operational environment, and we, confirm it's an heart failure patient, but for whatever reason, we can't fly him out for, 24 hours. What care plan should we look at? Should we think about diuretics to try and reduce the volume, dilators? What would your management plan be?
Yes, we will discuss this in a minute, but we can go ahead, and that would be my question to you. So how would you manage this gentleman? What kind of drugs would you give? Michael, you already mentioned some.
Yeah, well, definitely take him off whatever duty he's doing and put him at rest under observation. Cardiac monitoring, of course, and depending on what his kidney status is, we could consider some furosemide and maybe some nitroglycerin to try and titrate blood pressure to more normal levels. That'd be first line, and then if things really go south, we should start looking at probably some inodilators, but that'd be bit of a bigger gun.
Yes, very good point. Yes, Dennis, go ahead.
Like as far as using diuretics, I mean, I think in the hospitals, this is probably a no-brainer, but they also have supplies. If we start making them pee everywhere, you may not have the fluid to back it up.
Mhm.
So I would imagine you'd want to start real conservative and start inching your way back to normal, because the sats are not horrible. 97, I'm guessing, on room air. The only thing that looked really off to me was his heart rate, which makes sense with the block. I think you start slowly limping your way back, because I could see somebody over treating, and then you push them into being hypotensive with fluids and not being able to reel that back in.
Mhm. Yes, thank you both. Very good points. And yes, Dennis, you are right that we always have to be careful with the diuretics. It's it's actually easy to dehydrate the patient. So I would say that you need to treat the fluid overload, the volume overload, because it's within the lung. Is also has some edema. So you need to give some medication to help that condition, and on the other hand, you need to take care to hydrate the patient if needed, so you can supplement with the fluids. Okay, but meanwhile, while you are trying to figure out what to do with this gentleman, something really bad is happening, because he falls down to the floor and loses his consciousness. And as far as the ECG is still attached, you see this.
Does he have a pulse?
No. So let's discuss the ECG stripe first, and then we go on with the clinical management. Yeah.
It's in pulseless VTAC.
Yeah. I'm just reading the Tim said, look at slow, then go. Yeah. Okay. So it's a pulseless ventricular tachycardia. Mm-hmm. Yeah. Yes, it is a ventricular tachycardia. You don't have the grid lines on this one, but it gives a hint that the heart rate is 138, which is acceptable. Just in theory, would this so the a VT with a rate of 138, is it compatible with a pulse? So yeah,
Potentially, yes.
I think it's clear that yes. So this is a slow VT. So for being a VT, it's a slow rhythm, because fast VTs are around 150, 160 per minute. And but in this case, this gentleman doesn't have a pulse. So so you put on the Lucas, load and go. Yeah, what else? So it's definitely an ALS situation. And today I don't want to, Michael?
No, sorry, it's a mistake.
Okay, no worries. But you can tell me, what would you do?
An unsynchronized shock at 2 200 joules CPR, and if it's refractory to defibrillation, then we'll start going down either procainamide or amiodarone.
Yeah. Yes. Okay. So did you in the beginning you told me synchronized or asynchronous shock?
Unsynchronized if he's pulse.
Unsynchronized. Yeah. Okay. Yeah. So you would go down the CPR, the ALS guideline, and you would do your job. And you are very well trained medics, and this gentleman is really lucky because the cardiac arrest is happened at your focus, so he could get the immediate care. So the second defibrillation is successful, and the sinus is back, and here we go on. So you have a post-ROSC patient here, and you can assess again according to CCABC. The pulse rate is a bit higher now, the respiratory rate is quite high, and you give high flow oxygen in a non-repeating. So he's breathing, the vitals are stabilized, the blood pressure pretty low, and you get back the similar ECG as in the beginning, sinus with right bundle branch block. The GCS is not so good, so he's opening his eyes to pain, but when he's alert, he can communicate a bit, and he localizes painful with the motor movement, painful stimuli. Okay, the others are not changed. So we have this gentleman with a heart failure, possibly it's a viral myocarditis, quite alarming resting ECG, and VT with successful treatment. And you have this post-ROSC situation. How would you handle, how would you manage? Let's discuss what do we do in this post-ROSC situation. Oh yeah, Michael, post-ROSC heart failure with low blood pressure. Would you start fluids or skip and go direct to pressors? What do you think? Or anyone has any idea? Trevor, yes?
I would do both simultaneously. I mean, I get the blood pressure up with pressors and simultaneously start fluids, I think would be my personal approach.
Mm-hmm. So you simultaneously give the fluids and pressors. Okay, yeah. Mm-hmm.
I feel like I would avoid the fluids and probably start pressors while he's already overload. Like we're just gonna make it worse, right?
Yes. Yeah. In this situation, I will also be careful with the fluids because in the beginning he was already a bit overload. You can try just one round of a fluid bolus and see the response. So that's without further risk, just one round, and then careful. Yeah. Okay.
This might be a dumb thing to say, but
no, never.
I mean, is he really volume overloaded? Because the heart was what the problem was. He didn't receive so much fluid that he got this way. It's just the pump wasn't working.
Yeah, I get your point.
Yeah, now we shocked the crap out of it, and now it's working real well.
Yeah, I get your point. In this, to accurately assess the fluid status, we need a hospital environment. We would do a cath and measure the pressure situation, things like that. So we can, in this situation, we can only base on our physical findings and the measurements we have. Yes, you are right that it's a pump failure, and according to that pump failure, he has some edema in the peripheral tissue and also in the lungs. In the stem, he might not be truly overloaded with fluids, but still we have that fluid in the body within the wrong compartment, and that's causing symptoms to him. His breathing is not so bad even after the ROSC. He's receiving the oxygen, sure, but he's not in a severe respiratory failure. So the lung fluids, the lung is not a really bad edema, or you get the point that he is not in a respiratory failure. But still, I would suggest that treat it as consider it as a fluid overload, because the fluid is in the wrong compartment, and that's the problem, and you need to get that out of there. Otherwise, it will cause more symptoms. Okay. What else would you do in this post-ROSC situation? Okay.
Beg somebody to come get him.
Say that again, please.
Beg for somebody to come get him.
You mean to evacuate?
Yeah, as quickly as possible.
Yeah, sure. Yeah. Okay. Yeah, Tim, very good. The targeted temperature management. We can always think about that and consider the need of that. In this situation, as far as he is conscious, he regained his consciousness. You are not forced to intubate and ventilate him. He is alert. So in this given condition, I wouldn't cool him down. But very good point. We always have to, in general with ROSC, we need to think about the temperature management. Okay. So I go ahead and just show you, this is from your field guide, the post-ROSC care we can discuss. So what you do, you optimize the ventilation, the oxygenation, and you maintain the oxygen saturation. Here I would like to outline that the latest STEMI guidelines, they try to avoid hyperoxygenation, because that's harmful on the ischemic heart. So you are happy with oxygen saturation above 49, so you don't aim 100%, and you don't need to give 100% oxygen support throughout the ventilation when the patient is well oxygenated on air oxygen or something like that, Okay, you consider the advanced airway and the capnography if available. Try to avoid hyperventilation. Next point, to treat the hypotension, which we have in this scenario as well. So the systolic blood pressure is below 90 millimeters of mercury. You have an excess, IV or IO or whatever you have, and you can do the vasopressors, inotropes, and again, you always consider the treatable causes. You have here listed some drugs, and I will have another slide showing you the drugs. So I go on, and you do a 12-lead ECG. It's important. So none of you suggested to do one in this situation. Always, when you have time, the ECG is available. Yeah, don't waste your time on doing a 12-lead ECG in a post-ROSC situation. If you can do it in 30 minutes, then do it. 30 seconds, then do it. Okay, because it's really, really useful to have. And even in this situation, when you had a pre-VT ECG, it would be really good to see what's going on after. You look for acute coronary syndrome signs, and you try to get the patient to a coronary care unit if possible. You evaluate the neurologic state, and you do the targeted temperature management if needed. Okay, very good. So on this next slide, and I think this is really useful. This is from the European Society of Cardiology, ESC guideline for acute heart failure. And it categorizes the patient according to the clinical state and the symptoms. So first you assess the A and B. If there's a respiratory failure, then you treat that with oxygen, with ventilation, CPAP, non-invasive ventilation, and if needed, you intubate and ventilate. And then you assess the circulatory state and see whether there's a circulatory failure, so whether the patient is hypotensive. If yes, then that's a low cardiac output situation. The 10% means that it's less than 10% of the patients with acute heart failure has a low cardiac output in the acute situation. So it's not the ejection fraction here. And if you have a low cardiac output state, you use these drugs or consider using them. So you can give the inotropes, the vasopressors, the diuretics. You can consider a hypertonic saline plus diuretic. And as a last chance, you consider the mechanical circulatory support if available. It's not in the remote care, but in some countries, as far as I know, in France and in Germany, and we are starting here in Hungary as well to have pre-hospital ECMO. So that's a mechanical circulatory support which could save a patient. Yes, okay. Otherwise, the inotropics are on hand and available. The first line in acute heart failure is dobutamine, and cardiologists prefer dobutamine over dopamine in an acute heart failure situation. The reason is that there are more side effects with the dopamine, mainly in the occurrence of malignant arrhythmias. So the dopamine causes more VTs, sometimes VF, or just ventricular extrasystolia. So it's the heart tolerates, the failing heart tolerates the dobutamine better. Milrinone, it's not that widely available, and it's rather used in heart surgery intensive cares. You can give vasopressors, norepinephrine, or epinephrine as well, and you can give the diuretics. And here is stated as well that you can give one bolus of the hypertrophic saline and look for the response. Okay, the other line is when the patient is not in a circulatory failure, so the blood pressure is normal. And here you have two ways, when it's a true volume overload, or when it's a kind of so-called dry patient with heart failure. When there's a volume overload, then you go with the vasodilators to decrease the blood pressure and the overload. You give nitroglycerins, nitrates, nitroprusid. You go on with the diuretics, and you can continue if the patient is already on the general medications for heart failure, and you can go on with the beta blockers, ACE inhibitors. You can decrease the dose because this patient is not in a low cardiac output situation. So again, there are some studies when stopping the beta blockers and the ACE inhibitors in a volume overload acute heart failure situation, it's worsening the outcome. So it's recommended to stay on the drugs with lowering the dose. Okay, and we have the third round, which is with a normal circulatory state without volume overload. Here, according to the guideline, you still give the diuretic even without the overload, without the true volume overload. So that's what I mentioned before, that you have the fluid in the wrong compartment, and you can give inotropic drugs as needed. Okay. Yes. And this is another table summarizing the drugs available in cardiogenic shock. So this is the low cardiac output. So this block. And here comes up the levosimendan. Have you heard about this drug? This is not so old, so I would say that this is a new one. It's called Simdax, levosimendan Simdax. It's a calcium sensitizer. Any experience with levosimendan? No. It's the problem with this drug is that it's really expensive. Otherwise, it's a magical one. So it's a calcium sensitizer. It has a strong positive inotropic effect combined with a vasodilation. So it's an inodilator, which is the best combination for the low cardiac output state. And as far as it's too expensive, it's generally not used in the acute setting or in emergency department. In cardiology care, mostly it's used for acute on chronic heart failure. And besides its acute effect, it has some longer term enhancement on the pump function. So for once the patient receives, the chronic heart failure patient receives a levosimendan infusion, after 10, 12 days, we experience tiny bit improvement in the ejection fraction. So you can think about it's improves from 19 to 24. But for that patient, it gives some relief from the everyday symptoms. All right. The next one is the milrinone, which I've mentioned. It's a phosphodiesterase inhibitor. It's again an inodilator. It has a positive inotrope and a vasodilatory effect. It's very well used in heart surgery ICUs when needed. The isoprenaline. The isoprenaline is a beta-1, beta-2 agonist. It has a positive chronotropic effect, and it has some pulmonary vasodilatory effect, which is again useful in an acute heart failure situation. We can go ahead and then I ask the question. So the dobutamine is a beta-1, alpha-1, and beta-2 agonist. It gives beta-2 mediated vasodilation. It's a positive inotrope, positive chronotropic drug. And the dopamine, it's a beta-alpha dopaminergic agonist. It has a peripheral vasodilatory effect, positive chronotrope, positive inotrope. And in high dose, it has a vasoconstrictory effect. And as I've just mentioned, we prefer the dobutamine over the dopamine in acute heart failure patients. It's more tolerable and less arrhythmic events with dobutamine. And the noradrenaline, it's very widely used. It's an alpha-1, beta-1 agonist. It's a positive inotrope and vasoconstrictory effect, you need to be useful due to the strong vasoconstriction. The noradrenaline is very widely used in septic shock as well. Okay, so these are the pharmacological treatment for the low cardiac output state. Just in general, and thinking about this bifascicular block, can you think about a situation when you would rather choose the isoprenaline, dobutamine, dopamine over the noradrenaline? And you've already, some of you touched on this heart rhythm problem with this patient. Tim, how you mean post VF? Yeah, you can give it in a post ROSC situation.
What was the question again, Dr. Gara?
Yeah, so the question is that this gentleman had a bradycardia in the beginning. No, he didn't have a bradycardic tendency, so 57, and he had this weird ECG with the AV block, RBB hemiblock. So in which situation would you really go for isoprenaline or dobutamine dopamine? It's really simple.
If his blood pressure dropped or if he became extremely bradycardic.
Yeah, bradycardia, that's the answer. I might have made too complicated this question. Sorry for that. So yeah, so isoprenaline would be a really good choice if this patient would become too bradycardic with his trifascicular block, because it's a good beta-1, beta-2 agonist. Yeah, so sorry, I was too complicated with the question. Okay, so this is the end of this case scenario. And we are approaching the end of the time as well. So I would like to ask for any further questions, comments, any piece of this scenario that you would like to discuss more in the end.
So I guess how would you manage this patient since, we're already in the scenario, we're in an austere environment. How would you be treating aggressively? Would you be treating very unaggressively as far as vasopressors and things like that? Considering like logistically, you're probably pretty limited.
Yeah, that's a good question. Very good. So according to his post-ROSC assessment, and according to this severe hypertension and the really alarming basal physical signs, and I'm talking about the trifascicular block and the signs of the heart failure, the edema in the lungs and also in the peripheral tissue. Yes, I would say that I would be aggressive with the treatment in terms of I would really aim to support the heart function with inotropic support as soon as possible. And also I would try to, so we discussed that he's not in a true volume overload state. He's in this group with low cardiac output. So yes, I would also give the diuretics to get the lung rid of the fluid overload, not to make sure that he is not getting into a respiratory failure. And yes, I would titrate the inotropes as needed to get at least a low normal pressure state. And yes, according to, as far as we are in an austere environment, I would be really aggressive in the beginning, because I would I wouldn't want to get him, or I wouldn't want to see him getting into a worsening situation. And also because he has suffered an arrest, and we treated really successfully, and he is conscious and in a quite good neurological state. I would do everything to remain that status. How would you do, or what are your comments? Do you have a post-stroke ECG? No, we don't have a post-stroke ECG in this case. Yes, Michael, go ahead.
Does it make any sense to speculate whether or not this patient has some structural changes? And specifically, do you think with a low cardiac output like that, it would be mostly like a dilated cardiomyopathy rather than hypertrophic?
Yeah, so good question. That what is his background condition? So what is the original disease? And here, just from this hint in the beginning that he had fever and the diarrhea, it might be that this is a severe acute myocarditis. And I'm saying might because we can't make sure, we don't have enough diagnostic tools in the pre-hospital setting to say surely whether it's myocarditis or something else, another structural disease, a valve disease, being an acute coronary syndrome, a non-STEMI, for example. It still could be a non-STEMI in this case. He doesn't have the pain, he doesn't have typical symptoms, but otherwise we can't rule out that this 0.100%. So most likely is a myocarditis, a large severe myocarditis with an acute heart failure and with acute electric disorders in the heart. Yes, the structural appearance is, yes, it would be a dilation because the pump function is not as good as it should be, but it's not the classic dilated cardiomyopathy. Thank you.
And if this is secondary to the myocarditis, would the pump dysfunction be reversible? Like once you treat the infection, will it go back to normal ejection fraction? Yeah, good question. So we can't say that. There's no tool to evaluate, to guess, and there's no score to calculate who will be those patients who will have a reversible ejection fraction or who will stay with a decreased one. Just this week I saw a gentleman, he is in his 30s and he had a viral myocarditis back when he was a teenager, and since then he is living with an ejection fraction of 42, which is quite bad for a gentleman in his 30s, and it didn't improve since then. So it's constant since his teenage, and he can't work out. He's quite restricted in his physical activity because he's in a chronic heart failure. Yeah, so we at the moment, unfortunately, we don't have any drug to give for these myocarditis patients to try to enhance the long-term outcome. Yeah, I think lots of science is going on in this field, because it would be really good to make the myocarditis situations reversible. It's a very good point. Yes, Nelson? Tim, yeah, Nelson, you can go ahead if you have a question. Tim asked COVID. Sure, it could be COVID. Yes, Tim?
Okay. suppose this patient had a chest pain, and looking at the vital signs, the patient probably maybe would be hypotensive and bradycardiac. What would be the choice of drug of administration? Looking at some of the drugs, we may not be able to administer them since they are contraindicated for the vital signs that we'll be having. What would be your recommendation, Doctor?
Okay, let's clear. So let's make it clear. So you say that he is having chest pain, and he's hypotensive, right? And the question,
yes. And bradycardiac.
And bradycardic, chest pain, hypotensive, bradycardic. And I didn't get the end. What would be contraindicated?
What would be our choice, knowing that some of the drugs may not be able to administer them because of the contraindications?
Okay, so you have a patient with chest pain. He's hypotensive and bradycardic. So the chest pain is, so he has a symptom suggestive of acute coronary syndrome. So in this situation, I would consider going down the ACS pathway. And sure, I would evaluate the ECG if this would be this patient. Yeah, I would, with typical chest pain, typical symptoms suggestive of acute coronary syndrome, then I would definitely treat him with this ECG as an acute coronary syndrome, because it could be a non-STEMI, and we can't diagnose that. We don't have a troponin test on hand. So did this answer your question?
Yes.
Okay, good. Yes, Jennifer, go ahead.
Hi, doctor. I just have a question with regards to the temperature, target temperature for post-ROSC. So for pre-hospital care, I was reading a paper that because in pre-hospital we used to use like ice packs to kind of bring down the body temperature. But then I was reading a paper that trying to do it in the pre-hospital care environment is not really practical, because if we use ice packs, it causes shivering, and shivering causes an increase in oxygen demand. So what are your thoughts on that?
Yeah, okay, thanks. So yeah, if you decide to use and go for the targeted temperature treatment, I would say that use that tool that is available on your hand. So if you have a cooling box and you have a saline around 4 Celsius or whatever, then you can try using that, which we have in ambulance cars and on the helicopter as well in Hungary. So you can do that, but be very careful about the fluid overload. Otherwise, yeah, so if you only have the ice packages, as far as the targeted temperature control gives the patient so much better outcome, I would still go for that with the ice packages as well. It's better to give it a try than to do nothing at all. And it's okay. Also, so if the transport is not so long, if you can reach the hospital quite quickly, then this shivering activity and the counterbalance with the shivering wouldn't cause that much damage.
Okay, because yeah, I was just wondering with regards to maybe aiming for normal temp versus doing the ice packs, but I think you answered my question. Thank you so much.
No worries. Thanks. Yes, William? William, if you have a question, you can go ahead.
Can you hear me now?
Yes, we do.
I was saying it's maybe more just my curiosity, but is the environment that we're in with this patient contributing or exacerbating any of these symptoms that he's having? Are we at altitude? Are we in a tropical environment where there's some sort of disease process that's happening to make this worse?
Yeah, very good point that these would influence. So in this situation, the environment, it doesn't have any unique conditions. So it's not altitude, not a tropical one. It's just a remote construction, maybe on an ocean or something like that. So yeah, but you are really right that we could face even more challenge coming from the environment, and that would also influence the clinical situation.
Okay, thank you. Obviously, we're still going to treat the patient. I was just curious if there was something that we also could do to help.
Yeah, I mean, in a tropical,
make our treatment.
Yeah, in a tropical environment, you have to deal with the heat condition. It would be more difficult to reach target temperature control. Yeah, in the altitude, you need to fight the pressure difference conditions. So yeah, you very good point that in a remote environment, you always have to think about these unique situations as well. Yes, Michael?
I know there wasn't really much of a respiratory distress component at any point, really, except probably after post-ROSC. But initially, when patient presented with initial symptoms and blood pressure of 140/70, do you think there would be any role in putting the patient on CPAP with like a reasonable amount of PEEP to try and use that to lower the blood pressure as well and take a bit of stress out of the heart?
Yeah, okay. Yes. In this scenario, as you remember, the initial saturation level was 97. So the patient was not in hypoxia. So in this scenario, I wouldn't. But in general, very important point that you need to think about supporting the breathing with non-invasive techniques. So thanks for this point. Any further questions, comments? Okay, I have prepared another case for you today, but you were really interactive, and thanks for that. So we had a really good discussion, and I will talk to Abric, and we'll see what will happen with the other case, because I would be really happy to present that as well for you. And if any more questions come up, feel free to email us, get in touch. We are around to help you. Hope that this event was useful for you, and have a good evening and take care.
It's okay.